So now some points about SSRIs. Though we have discussed most of the points about SSRIs, but still there's addition of 1 to 2 more point and a short revision. We all know that SSRI, they are first line in the treatment of majority of the patients with depression. Stelopram and fluoxetine, they are usually the preferred SSRIs. Stelopram in adults and fluoxetine in children and in adolescent age. Now the SSRI that is useful in the treatment of depression in patient with myocardial infarction, or if a patient is breastfeeding, then our choice would be sertraline. And in children, our choice would be fluoxetine. Now the common side effect of SSRIs other than serotonin syndrome. Serotonin syndrome is basically due to overdose or toxicity of SSRIs. The other common side effect of SSRIs, the most common are gastrointestinal symptoms. So gastrointestinal symptoms are the most common side effect of the SSRI. There's an increased risk of gastrointestinal bleeding in patients who are taking SSRIs. So that's why if a patient is taking SSRI, so we'll use or avoid concomitant use of NSAID, aspirin, warfarin, because the chances of bleeding will increase if SSRI are used with NSAID, aspirin, or warfarin. That's why if a patient is on warfarin, then we do not use SSRI, but we use atypical antidepressant such as mirtazapine. We all know that SSRI can take 2 to 4 weeks before antidepressant effect can be seen. If no response after 2 to 4 weeks, we will check the patient adherence. And if the patient adherence is good and still there is no response after 4 weeks, then we can either increase the dose or switch to another antidepressant other than SSRI such as mirtazapine. For example, a woman with moderate depression has been on fluoxetine for 8 weeks, but with no benefit or improvement. So if a patient presents to you who is on SSRI and there's no benefit or improvement, first of all, you will check the adherence. If the adherence is good, then what should be done next? We can change to another antidepressant such as atypical antidepressant, that is shift to mirtazapine. We all know that lithium is for bipolar disorder, sodium valproate, they are used in their anti-epileptic medication, and ECT is usually our last option if depression does not respond to any of the medication, then we'll go for ECT. So the answer here is stop fluoxetine and prescribe mirtazapine. And if in the options increasing the dose of fluoxetine was given, then it might have been a valid answer as well. So if a person who present to you with no improvement in the condition after the use of SSRI, then after checking the adherence, you can increase the dose or change to another antidepressant. Both of them can be the right answers. So gastrointestinal side effects are the most common one. Other side effect of SSRI, they include anorgasmia, that is delayed ejaculation. So SSRI, they can lead to anorgasmia, that the person will have normal erection but delayed ejaculation, while the person on haloperidol, he will have erectile dysfunction. erection will not be normal. So remember this difference, that haloperidol and SSRI, both of them can cause sexual dysfunction. So if there is delayed ejaculation, then the cause will be SSRI. And if there is erectile dysfunction along with gynecomastia, then the cause will be haloperidol or antipsychotic medication. SSRIs can also cause ADH, that is syndrome of inappropriate ADH secretion, which can lead to delusional hyponatremia. So this is a side effect of SSRI as well. So gastrointestinal side effects are the most common, then anorgasmia, and then SIADH. These are the side effects of SSRI that you need to remember for Plab 1 exam. Now, another side effect that is specific that can cause acute closure angle glaucoma, that SSRI is citalopram. So a specific side effect of citalopram is that it can cause acute close angle glaucoma. So if someone is on antidepressant medication and he develops painful and red eye, then you will urgently refer the patient to ophthalmology. For example, a patient in depression switched from fluoxetine to citalopram presents with painful red eye and visual blurring. So what is the best step in the management of this patient? You will refer the patient to ophthalmology. You will urgently refer the patient to ophthalmology because acute closure angle glaucoma is a side effect of citalopram. Remember, the drug is citalopram and not escitalopram. Both of them are different drugs belonging to the same category, but their chemical structure is different. So closure angle glaucoma is a side effect of citalopram. Now another example, an old patient accompanied by his son present to A&E with low mood 6 months after his wife's death. So low mood after the wife's death is it's most likely depression. He's having suicidal thoughts and does not want to live anymore. His son is concerned about his father. He takes warfarin for atrial fibrillation. What is the most appropriate management? So what is the most appropriate management in this case? Who will tell me the answer of this scenario? Which antidepressant can be used in this scenario?
Retazepine.
Yes, excellent. Metazepine, atypical antidepressants such as metazepine can be used. It was a first-line drug, SSRI. They are contraindicated along with warfarin. So that's why. So in the same patient, if the same patient present to you with low mood for less than 6 months, then what would be your diagnosis? After a major life event such as death of a loved one, if a person present to you with signs of depression and the duration is less than 6 months, then what will be your diagnosis? If the duration is more than 6 months, then it is depression. And if the duration is less than 6 months, then what can be the cause or what can be the diagnosis?
Grief reaction.
Yes, normal grief reaction. If the duration of the symptoms is less than 6 months, then it's normal grief reaction. Because normal grief reaction is a 5-stage process, and one step of normal or one stage of normal grief reaction is depression. So if the duration of symptoms is less than 6 months, then it will be normal grief reaction or adjustment disorder. And if the same patient with after a major life event present to you with nightmares and flashbacks, then your diagnosis will be post-traumatic stress disorder. So these conditions three can occur after a major life event, that is depression, grief reaction, and post-traumatic stress disorder.
Doctor, can you repeat the post-traumatic stress disorder, the time duration?
Post-traumatic stress disorder is if someone present to you with flashbacks and nightmares after a major life event or accident. So if the main feature is a nightmare and flashbacks and avoiding the situation or the events that resemble those that event, then it will be post-traumatic stress disorder. So the presentation of post-traumatic stress disorder is different from depression and from normal grief reaction or adjustment disorder.
No specific time limit, right?
Can you please speak a little louder?
There is no specific time limit.
There is no?
Specific time limit, like 6 months, 6 weeks.
Yes, there is
like
no
this.
specific time limit for post-traumatic stress disorder.
Okay, doctor. Thank you.
Post-traumatic stress disorder can occur within 6 months, after 6 months. There is no time limit. The time limit is only to differentiate between depression and normal grief reaction. So a patient who are taking warfarin or heparin, they cannot be prescribed SSRI for depression. They should be given mirtazapine. Now, what is the drug of choice or first line drug for the treatment of psychotic depression? Someone with the signs of depression plus psychotic symptoms, the diagnosis will be psychotic depression. Normally, the first line drugs for the treatment of depression is SSRI. But if someone has feature of psychotic depression, then the drug of choice will be tricyclic antidepressant such as amitriptyline. So a 32-year-old man presents with erectile dysfunction of 2 months. He had depression 3 months ago and was started on sertraline. He has no medical history. Know what is the most likely cause of his symptoms? So we have discussed that one of the side effects of SSRI is anorgasmia, loss of libido, or erectile dysfunction as well. So in myocardial infarction, sertraline is the first line, and if sertraline is not given in the option, then citalopram is the second line. Patient on warfarin and heparin, mirtazapine is the first line, and depression not responding to SSRI, then mirtazapine can also be tried, and amitriptyline or TCAs, they are the drug of choice for the first line drug in the treatment of psychotic depression. Now, we will discuss some points about acute psychosis. What will you do or how will you manage a patient of acute psychosis? Remember that 3 drugs can be used in the management of acute psychosis. That is, lorazepam is usually preferred, the first line drug, then haloperidol, and then olanzapine. All these 3 drugs, they can be given IM, so they can be used in the treatment of acute psychosis. Remember that normally, in general, in elderly people, haloperidol is the first line drug for the treatment of acute psychosis, and in young people, lorazepam is the first line drug. So in acute episode of psychosis, the drug of choice is haloperidol, especially in elderly. Remember that because antipsychotic medication, they can cause Parkinsonism, So we cannot use haloperidol if someone has a history of Parkinson's disease or Alzheimer's disease. So normally in elderly population or in elderly people, the drug of choice to treat acute psychosis is haloperidol, except in two categories. If the elderly person has a history of Parkinson's disease or Alzheimer's disease, then we will avoid the use of haloperidol and instead we will give lorazepam. For example, an 80-year-old schizophrenic man is brought to the emergency department, agitated. He is aggressive, attacking the staff. He has no IV access. So a person, an 80-year-old schizophrenic, has developed acute psychosis, that is agitation, aggressiveness, and attacking the staff. He has no IV access. So haloperidol, because he is an elderly person. So in elderly people, haloperidol is preferred over lorazepam, because according to 2020 NICE guidelines, low dose haloperidol, or if there is any contraindication to low dose haloperidol, then low dose lorazepam can be used for the treatment of acute psychosis in elderly people. So in elderly haloperidol, and in general lorazepam is the first line drug. Also, if the elderly has Parkinson's disease or Alzheimer's disease, then again lorazepam will be given. Now let's do another example. A 30-year-old woman. So a 30-year-old woman is brought to the emergency department by the ambulance in agitated state, agitation, roaming around the street, shouting and laughing hysterically. So agitation and shouting and laughing hysterically, throwing money and saying, "I am going to die." She was admitted compulsorily. However, she continues to be agitated and try to escape from the hospital. So this is a case of acute psychosis. The patient is young, so lorazepam will be given. So in young people, lorazepam is the first line drug to treat acute psychosis, and in elderly, haloperidol is the drug that is used in acute psychosis. And if there's history of Alzheimer's disease or Parkinson's disease, then in elderly, we'll also use IM lorazepam as first line drug. Again, an example of a 37-year-old man who is shouting at his wife and neighbor. So again, the patient is young, so we'll give lorazepam. Remember that lorazepam is a short-acting and rapidly acting drug, so that's why it is used in the management of acute psychosis and not diazepam, because action, the onset of action of diazepam is slower in onset. Now, what is lack of insight and insight? Lack of insight means if someone has a problem, but he does not recognize that he has a problem, then we will call it as lack insight. And if someone has a problem and he recognizes that problem, then it is known as insight. For example, if a 24-year-old female had misused a drug and presented to the emergency department on her own, as she knows that she has a problem and is willing to see a psychiatrist. So she knows she has a problem, so this is insight. Another example of now an elderly with Parkinson's disease develop acute episode of psychosis. So though we know that the drug of choice in elderly patient for the treatment of acute psychosis is haloperidol, unless the patient has a history of Parkinson's disease or Alzheimer's disease. Haloperidol can be used in acute delirium, acute psychosis. It can also be used in the nausea and vomiting. Remember that you will study it in the chapter of palliative care as well. that haloperidol is the drug of choice in the treatment of nausea and vomiting due to metabolic causes, such as chronic kidney disease. So, other than its use in acute psychosis, haloperidol can be used in the management of nausea and vomiting due to.
So it can be used in these two Alzheimer's, like a vascular, sorry, in dementia and Alzheimer dementia,
Now,
because
haloperidol is written in the Plab that it is provided in Parkinson disease and in dementia with Lewy bodies, and it can be used in uh, Alzheimer dementia or vascular dementia. But the Plab is right, different from Plabable. That is, uh, haloperidol should be avoided in a person with dementia in general.
right,
So I don't know what is the updated guidelines in the Plab keys, because the version of the Plab keys that I have is an offline version. So maybe it's outdated. Uh, so I'll go with this Plabable explanation that we do not use in Parkinson disease and in Lewy body dementia. In other dementia such as Alzheimer dementia or vascular dementia, haloperidol can be used. Anyhow, you can confirm it from the latest guidelines or the latest questions. You will find your answer there.
right.
So there's one more condition in which we avoid the use of haloperidol. An agitated man who is being confused and aggressive, so acute psychosis and medical history is unknown. If medical history is unknown, we'll use lorazepam to be on the safe side. If medical history is known, such as uh, if the person has a history of Lewy body dementia or Parkinson, then we'll use the medication accordingly, such as we'll use lorazepam. And if there's no medical history of these diseases, then we can use haloperidol or olanzapine as well. Remember that we will always use oral medication first if the patient would accept. And if the patient is not accepting the medication, then we'll use the injectable form of the medication. Remember that haloperidol, it cannot be used in a patient with a history of cardiac diseases. So Parkinson disease, cardiac disease, Lewy body dementia, haloperidol is contraindicated. IM lorazepam is safe in all the cases. So this was all about the management of acute psychosis. I hope it's clear to anyone. If there is any confusion, you can clear your confusion by asking question from me. So is there any question?